Good afternoon, and welcome to the fourth and final session of this symposium titled Innovative Prevention and Treatment of Both HIV and TB. I'm Dr. Dilip Matai, Professor and Dean of the Apollo Institute of Medical Sciences, located at Hyderabad in the central part of India. This session that we would be having will focus mainly on the innovative prevention and treatment of both HIV and TB, and will outline the advances in TB therapeutics and how they can be applied in South Asian situations. It will present the perspective of people living with HIV and TB, as well as communities, to complement the clinical perspective which our learned speakers would be presented. We have a very interesting lineup of speakers, four speakers for this session, who will be commenting on this topic and will participate in a question and answer session during which you, the audience, will have the opportunity to ask them questions. We sincerely hope that this program will be of value to you, particularly in your current sphere of work. Before moving on to this presentation, I would like to share some housekeeping rules. The housekeeping rules: now all participants are currently muted, except me. Now, I invite all those connected virtually to please introduce yourselves by typing in the chat box or that interactive box that is right beneath the screen. And you will see that your message shows in the interactive box to the right of the screen. Please type your first name, last name, the organization you work for, and the country you are from. Let's use this opportunity to connect and get to know each other. So if you can do that, that would be fine. If you're having technical issues and are unable to see the chat box, I would like to invite you to change your internet browser and to select all cookies to be able to interact with the speakers when entering onto the platforms. Please use the same chat box during the question and answer time that will take place right after the presentations. You're also welcome to send comments into the chat box. Now, we have a small membership offer. I think it's very attractive. As an active participant of this IAS Educational Fund Symposium, you have the opportunity to benefit from an IAS membership special offer. Buy 1 year membership, get 6 months additional extra for free. Buy a 2-year membership, get 1 year extra for free. So you've got it on the screen. As to take advantage of this offer, you could reach out to member service @iasociety.org. Okay. So now I would like to show you the speaker lineup. We have 4 speakers, and Dr. Sanjay Pujari, Rajan Casey, Dr. Himali Perera, and J. Robin. And for our first speaker, we have Dr. Sanjay Pujari, who's the Director and Chief Consultant at the Institute of Infectious Diseases, Pune, India. He will present recent advances in TB therapeutics and their application in South Asia. Over to you, Dr. Sanjay Pujari, and you may begin your talk, and you have 12 minutes. I think you have a pre-recorded version. Yes.
So today we discuss some of the recent advances in TB therapeutics, not really focusing much on treatment of latent tuberculosis and their application in South Asia. This is the outline of my presentation. I'll first be talking about drug-resistant TB advances, subsequently some of the DRTB trials, and finally challenges in implementing these therapeutic advances in our region. As far as drug-sensitive TB is concerned, there has been increasing focus on shortening the duration of short course treatment, and this is a trial which looks at patients who are randomized with drug susceptible TB to control versus rifampicin based regimen along with the standard first line drugs replacing rifampicin and rifampicin moxifloxacin for 4 months, which is replacing ethambutol with moxifloxacin. And as you can see here, there is no difference in terms of the absence of tuberculosis disease-free survival between the rifampicin moxifloxacin regimen as well as the control regimen. This was not true only with the rifampicin-based regimen. As far as adverse events are concerned, again there was no difference in the frequency of adverse events, grade 3 or higher, between rifampicin moxifloxacin versus the control regimen. In a subgroup analysis in the same trial, which looked at people living with HIV, the rifampicin moxifloxacin regimen was non-inferior to the control regimen, but this was not true only with the rifampicin-based regimen. In a patient-level pooled analysis presented recently at CROI, you can see that stratifying individuals according to low, moderate, or high risk based on CT value as well as severity of involvement radiologically in the lungs. The regimen of rifampicin moxifloxacin actually worked better, including the only rifampicin regimen also worked better in individuals with low risk versus individuals with high risk. The implication of that is trying to look at whether we can use a individualized approach rather than using a one size fits all approach. In terms of pediatric drug susceptible tuberculosis, this is data from the SHINE trial, which demonstrates a shorter regimen for children with non-severe tuberculosis. We all know children are usually having paucibacillary disease. Were randomized to 4 months of intervention versus control only of 6 months with using the same first line drugs. And as has been seen here, there is no difference in unfavorable status by 72 weeks between the two groups. And also there is no difference in the grade 3 adverse events between the two groups, perhaps making it, perhaps proving that this regimen of four months is really not non-inferior or different from the standard 6 months regimen for drug susceptible non-severe forms of TB in pediatric population. Further trials are going on looking at further shortening the duration of treatment for drug susceptible TB. This is the Truncate TB trial, where individuals are being randomized to standard management of 6-month treatment with 2 months of boosted regimen, and if with close follow-up having relapses, subsequently being offered a 6-month standard regimen. This trial is ongoing and we expect results later this year. The abbreviated regimens include 8 weeks of high-dose rifampicin with linezolid, 8 weeks of high-dose rifampicin with clofazimine, 8 weeks of rifampicin with linezolid levofloxacin, and Group E is without rifampicin, adding linezolid and bedaquiline. So this would be an interesting trial to see what the results are, which may well mean that drug susceptible TB treatment would be for weeks. In terms of drug-resistant TB, there are few trials which are of interest and published recently. This is the next TB study in patients individualized in patients with MDR TB or RR TB randomized to conventional injection based versus interventional all 5-drug oral regimen, which included group A drugs of the WHO with 1 or 2 drugs from the group B or group C. And in this trial, actually the all oral regimen was better than the injectable regimen. This trial was stopped in between in South Africa when bedaquiline became the standard of care for treatment of tuberculosis, and this was also useful in the subgroup analysis of modified intention to treat population in HIV infected individuals. The next TB trial actually randomized, it's a single arm study which looked at a 3-drug regimen of bedaquiline, pritomanid and linezolid for XDR and MDR tuberculosis, and almost 90% individuals had favorable outcomes with this. The only problem with this was high toxicity associated with the linezolid use of peripheral neuropathy and myelosuppression. To address this, the Xenix trial looked at varying doses of linezolid from 1200 mg for 6 months to 600 mg for 2 days. It's a randomized trial looking at 6 months follow-up after treatment initiation, where they demonstrated reasonable treatment success rate across all the 4 groups, but a significant lowering of peripheral neuropathy and myelosuppression in the lower dose groups, trying to prove the point that lower doses of linezolid may be less toxic but equally efficacious in the management of DRTB. Finally, the TB practical study, one of the most important studies in patients confirmed with RR-TB randomized to a BPAL clofazimine, BPAL moxifloxacin versus standard of care. The DSMB stopped this trial in between because of 3 standard deviation superiority of the BPAL moxi regimen over the standard of care. And this is what you can see here, the non-inferiority margin being met by BPAL moxifloxacin, both in modified intention to treat analysis as well as per protocol analysis. In terms of adverse events, you can see here the BPAL moxi regimen was having a lower frequency of SAEs or new grade 3 adverse events, proving that it may be reasonably safe to use. Finally, we'll talk about challenges in implementing some of these therapeutic advances. And one of the biggest challenges we all have faced across the world has been the impact of COVID-19 on TB services. And this data shows you from the WHO report a dramatic decline in TB notifications and slight increase in TB mortality happening over the last year, 2020-2021, because of the COVID pandemic. Not only this, COVID pandemic actually has reversed the gains that we have made in ending TB strategy, with 11% reduction achieved in TB incidence rate as compared to the target of 20%. And so is true with other metrics like TB deaths or percentage of patients facing costs. So the challenges are really many. One of the most important is, of course, access and affordability to the drugs. And bedaquiline use, fortunately, in our region is accessible either through program or compassionate use or access. So high prices and restrictive patents make it very difficult for these drugs to get access to in lower and middle income countries in the region. So programs or governments needs to look at implementing or establishing compassionate use and expanded access program. The other aspect is, of course, increasing drug resistant capacity, particularly rapid drug resistance testing for existing, new, and repurposed drugs, unless you identify what proportion of patients have this. The implementation of algorithms for management of this may not be really useful. This is demonstrated in a large gap between estimated and detected and reported cases of TB globally, including in our region, especially for drug-resistant TB. The third aspect is, of course, access to radiology. And radiology, now we have ultra-portable digital radiography systems and artificial intelligence-based software for reading radiographs, which may be useful in trying to scale up diagnosis of tuberculosis and implementation of treatment protocols. Finally, many strategic and operational issues, including translating rapid pace in advances into policy and implementation, because things are moving very fast, and it's extremely important for programs to be malleable to advance to include these advances into implementation. The issue of human resources scale up, including rapid advances, information dissemination, and training. Especially now, WHO has had a new definition of XDR-TB, where they include resistance to group A drugs as one of them. Surveillance is another important issue. Social support to patients also needs to be scaled up in the context. Finally, some of the challenges in further research questions include data on patient subgroups, especially children, pregnant women, people living with HIV, diabetes, and extrapulmonary TB, mechanisms of resistance to newer drugs and genetic markers of those. Prevalence of resistance to newer drugs needs to be studied. Drug-drug interactions, especially in the HIV infected individual populations with the antiretroviral and other medications. There needs to be data for some of these newer and repurposed drugs in the PK across ethnicity and underlying comorbidities, age, and gender. And finally, we need to look at optimizing the dose of studies looking at optimizing the dose, especially for linezolid and clofazimine. So, in summary, future TB treatment is going to focus on shortening the duration of TB treatment, both for drug susceptible as well as drug resistant TB, including new or repurposed drugs. It is very, very promising that the evidence for shorter treatment, especially for drug TRTB, is extremely exciting, and this needs to be rapidly scaled up into policy and implementation. Barriers to treatment access must be addressed urgently, and this includes patent issues as well as use of these newer drugs, especially protominate or delaminate, in the context of compassionate access or expanded access programs. And finally, there needs to be a greater investment in trying to address further research questions to optimize TB treatment and to make TB treatment shorter, more safer, less pill burden, and maybe improve the quality of life of patients infected with both drug resistant and drug susceptible tuberculosis. So thank you.
Thank you. Thank you, Dr. Pajari, for the very interesting presentation. You really covered the whole gamut from drug susceptible to drug resistant and the XDR TB and pediatric TB. Very nice presentation in this short period of 12 minutes as such. Now I'm pleased to introduce our second speaker for this session, Rajan Kumar Kesi, who is the secretary and a founding member of the National TB Network in Nepal. Rajan is a member of the community of people living with HIV in Nepal and has worked with many key population groups throughout the country. He provides training on HIV, TB, drug addiction, as well as leadership development and advocacy roles. Mr. Rajan is currently a member of the TB Technical Working Group for people living with the disease, which is part of the Health Ministry, and he oversees the National TB Program in Nepal. He will present in the next 14 minutes where to from here and provide his comment on advances in TB therapeutics from the perspective of key population in Nepal. Over to you, Mr. Rajan.
Okay, namaste everyone. I am Rajan Kesi from Nepal. Represent people living with HIV and people living with disease, TB. First of all, I would like to thank IS 2022, ASA Foundation, and Julia and the entire team for giving me this opportunity to share my personal experience, my learning as a community people. Today, I'm sharing some of the issue of people living with disease, especially HIV and TB, which is focus on keeping HIV response effective in pandemics, on title in recent advance in TB therapeutics and their application in South Asia. Also, I can discuss on current situation our uh, learning during pandemic situation and where we are now and what we want in upcoming days as well. So first of all, I would like to share some panic situation of Nepal during last pandemic. We all know COVID had changed the lifestyle of human being, all humankind. Uh, on this pandemic situation, Nepal has also imposed country lockdown. Especially COVID is effect on health issues of the whole health sector, especially. Uh, so we are also survived that kind of situation. There is a lockdown, restriction, transport problem, and unable to reach service site, get medicines, ART or dogs. It's a very kind of complication and problem which has faced that time. But good things that the implementers of HIV care and support program in Nepal, which is led by people living with HIV national network. So most of the areas, the community mobilizers of our CSBC, community and home-based care staff member has been provide door-to-door approach to deliver ART medicines of PLHIV. That is our good point in HIV services. Same as in TB. Most of the implementing partners has been mobilized their enriched worker to deliver TB medicines in community or infected people's. So there was no any that kind of case we found during that time. Okay. Nobody is lost their daily dose during this pandemic. Another thing is a national TB program has developed interim guidelines, same as HIV. So during that time, how we can approach the services during this pandemic situation. So in that interim guidelines is every dose center has been provide 1 month dots medicines to each TB patients under supervision of family members. That is another part of Nepal government or national entity. So that time is very panic situation for us, but Nepal government, the national entity has been fully support to save our life, mobilization, medicine providing, COVID. Unfortunately, the time is now not in the same always. So that time is past, already passed. So, but that is a learning time. we can learn many things during this uh, time. So in upcoming days, we are also requested to national entities, TB or HIV, to develop some kind of activities for community system strengthening or community response activities, which are focused on community empowerment, community involvement. Uh, also, so we are learning many more things on this pandemic situation. So based on our learning as a community representative, I would like to share some challenges and recommendation from community people. First thing is logistic problem. And there are still minimum logistic or logistic management system is very weak nowadays in Nepal, because there are lengthy process in government for procurement. So sometime the ART medicine has been stock out. On that situation, we are faced some kind of problem in for certain days. But now globally we are promote or starting in a multi-month dispensing approach, so we have to adopt should start MMD approach in Nepal for community betterment, save the other communities, social discrimination, health setting, workload pressure, that kind of issue has been minimized if we wish to start multi-month dispensing approach. Another, we have to work on mental health. That is another major part in HIV and TB as well. So we are also, as a national TB network, we are trying to work on these issues, and we are also consulted with some of our counseling agencies for provide us some kind of technical support in mental health issues. So I am also requesting all government or non-government global partners also to support or initiate in mental health problem of PL-HIV and TB survival. Another is we have to work on community lead response activities. Now we are know about our right, our human right, our health right. So everyone have to know about their rights. So we have to work on community lead response, community involvement activities, community empowerment activities. So we have to work on by and for approach. So we are formed as a national TV network for, especially on this approach. We want to do something for our community. We wanna kind of develop some kind of bridge within government and impacted population. So I would like to request all of national entities and global partners for initiate that kind of platform for community or develop that kind of an initiation for community involvement. Another things is community-based ART is now needed because of this our last pandemic situation faced many kind of these issues about access of ART treatment or DOT treatment. So we have to initiate community-based ART or community-based DOTs is another essential service for upcoming days. Another things is sustainability activities. There are no any sustainability activities in in our country. So both we have to need both in both disease for sustainability activities to self-sustain or dignified life of people living with HIV and people living with TB. So we have to work. If we work on this recommendation, I think many of issues which we faced nowadays has been minimized. Okay. At the last, not the least, once again, thank you everyone for this platform. Okay, thank you.
Thank you, Mr. Rajan, for this interesting presentation that you have made. You have highlighted your country's problems of logistics resulting in the impairment of care for HIV and TB affected patients, and also concerns about the advocacy issues and the human rights and people's rights and how you need to get their buy-in in order to make both these programs successful. And you have also alluded to the problems that both these programs face because of the pandemic as such. Anyway, now we will now move on to the next presentation. For the third speaker for this afternoon and for this session is Mr. Robin, who is a counselor from Swam, Chennai, India. Robin will talk to us about his perspective as a person living with HIV and TB. Mr. Robin, the floor is yours for 6 minutes. Over to you. Thank you.
I'm Robin. I'm HIV positive, and again TB infected person. I'm 45 years old. I got married, wife, and 2 children, male children. I infected 2012. So I'm 2012, 2013 I infected with TB. No more support that time. Only when support my wife. I'm Kothi community, gay Kothi community. I'm living with HIV plus TB. Living 2-3 years. I'm very sad. I'm not overcome to my family. How I will run my family? How will manage my family and children? Very beautiful children and sweet, very small children. It's my support only for my wife. That time my wife very crying. That time very sad. That time I'm taking the 6-month tablet with TB. Again, 3 months before 3 months, I am very scared. I'm not standing my leg. I'm not walking. I'm only bedridden. I am that time. So I'm very sad. My support only for my wife. And other gay community, Kothi communities also call the phone. Robin, you take yourself and take care of your health. Anytime you call me and any help also. So I'm not taking the support to my Kothi communities. That time, my family situation also. So many discrimination also. My families, my mother, my brothers, sisters, also many people also discrimination. My neighbors also. I'm not sleeping. I'm very scared. And that time, no job, no money. So many problems I handled. It's no income. So my wife also making a small uh, um, food, daily food, making food, serve other people. So earn little bit money. That time, not enough for my family, but manage that time, manage. And after 6 months, I required the TB, but required the TB and taking the HIV tablet also. After 1 year, after 1 year, again family situations, no money. I'm going the begging. I'm going the begging also. My with my Kothi communities. I'm begging. That time sex work also. So many problems I'm having my life. And that time only support only for the my wife also. So she accepted. I'm gay. I'm Kothi community. I'm HIV positive. I'm TB also. So it's very impression my life. That is the my life. So many time, I'm one advice for the other people. Please be careful. Your life is very short, but be careful. Life, enjoy and sex and avoid the TB also. So many social workers also good job this TB infected persons. So the great job TB workers. So thank you the TB workers and social workers. Please accept that HIV is not curable, but this living HIV, but TB also curable. So the support people, TB people, so you supported all the peoples. This is my the concern as my request. I'm happy with enjoy the family with my wife also with sex with me and with condom. She's negative now. Now is tested also negative. I'm only positive. Children are negative, wife negative. I'm only positive. Now I'm 2012 infected. I'm living with God grace. So thank you. Enjoy the life. Thank you, Julia. Thank you so much.
Thank you. Thank you, Mr. Robin, for sharing your personal viewpoint, the trials and the tribulations that you had gone through along with the wife and also with the two illnesses of HIV and TB. Now, I would now like to move on to the fourth presenter, Dr. Himali Pereira. Dr. Himali Pereira is HIV care coordinator at the National STD AIDS Control Program of Sri Lanka. She completed her basic medical degree at the Faculty of Medicine, University of Colombo. She also completed her MD in venereology and trained in Royal London and Barts NHS Trust in 2010. She is a trainer and examiner for postgraduate doctors in the field of venereology and has local and international publications in relation to STDs and HIV. Dr. Himali, in the next 10 minutes, would talk about where to from here, and let us hear a comment on advances in the TB therapeutics from the perspective of implementation in Sri Lanka. Over to you, Dr. Himali. The floor is yours for 10 minutes.
Good afternoon, everyone. First of all, I would like to thank International AIDS Society, Educational Fund, and Asha Foundation Symposium, giving me the opportunity to present this lecture on where to from here, comment on advances in tuberculosis therapeutics from the perspective of implementers. During this 10 minutes time, I would like to discuss the following: HIV situation in Sri Lanka, TB situation in Sri Lanka, HIV-TB co-infection in Sri Lanka, advances in TB therapeutics in relation to HIV, and challenges faced when implementing TB therapeutics among HIV patients. As you all know, Sri Lanka is an island consisting of 9 provinces and 25 districts. HIV prevalence among general population is 0.02. HIV case rate is highest in the Western province, which consists of 3 districts, namely Colombo, Gampaha, and Kalutara. This chart shows the number of annually reported HIV cases since the year 1987 to 2020. As you can see, since the year 1987 to 2020, there is a steady increase of total number of HIV cases, and mainly with the male patients. However, female patients remain almost steady. This line graph shows the people living with HIV since the year 2000 to 2020. There is 5% reduction during the year 2020. This line graph indicates HIV new infection. It has been reduced by 57% from the year 2000 to 2020. AIDS death also reduced by 56% since the year 2010 to 2020. As you can see in this horizontal bar chart, commonest mode of HIV transmission is male-to-male sex in Sri Lanka. This map shows the antiretroviral treatment clinics distributed in all 25 districts, which provide care, treatment, and support for these people living with HIV patients in the country. So let's move on to tuberculosis. This map shows the TB cases detection by district in Sri Lanka. Highest number reported from Western province, which consists of 3 districts, Colombo, Gampaha, and Kalutara, and then comes the central province. TB new cases detection varies from 6,000 to 8,000 since the year 2007 to 2020. However, in 2020, there was a 5.6% drop of new cases, may be attributed to COVID-19 pandemic. This line graphs indicates all cases of TB since year 2005 to 2019. New cases of TB compared to previously treated cases of TB are more, as well as pulmonary tuberculosis cases are more when compared to extrapulmonary cases of tuberculosis. This line graph and the bar chart shows screening of HIV among TB patients from the year 2010 to 2019. Screening for HIV among TB patients started in 2013. So during the year 2019, out of the TB patient diagnosed, 7,690, 6 were positive for HIV. In addition, 30 non-HIV patients got TB infection. Altogether, 36 patients of TB HIV co-infected identified during the year 2019. Let's move on to the advances in TB therapeutics. This is WHO Consolidated Guideline published in 2021. In April 2021, WHO convened a guideline development group to review data from a trial conducted in 13 countries that compared 4-month rifapentine-based regime with a standard 6-month regime in people with drug-susceptible tuberculosis. The guideline development group considered a 4-month regime composed of rifapentine, isoniazid, pyrazinamide, and moxifloxacin that met the non-impurity criteria set in the trial protocol. The available evidence supports the use of this regime as a possible alternative to current standard 6-month regime. The shorter regime showed similar performance to the current standard regime in terms of both efficacy and safety. The 4-month regime is shorter, effective, and can be taken orally. It would be preferred by many patients, and it has a fast cure, easing the burden on both patients and the healthcare system. However, implementation and uptake of the new regime in the short to medium term will be more feasible if the cost of rifapentine is reduced and the availability is improved. So Sri Lanka updated the ATT guideline in 2021. So the treatment category divided into new and the retreatment. For the new patients, 4 drugs for 2 months and 2 drugs for 4 months were recommended. And for the reactivation, 4 drugs for 3 months and 3 drugs for 5 months were recommended. This is the ART consolidated guideline published in 2021 in Sri Lanka. The adults and adolescents, children living with HIV with no signs and symptoms of TB, rapid ART initiation on the same day is considered. And adults, adolescents, and children living with HIV with suspected TB, rapid ART initiation is recommended. Adults, adolescents, and children being treated for HIV-associated TB, ART should be started within 2 weeks of initiation of tuberculosis. And HIV-associated TB meningitis among HIV patients, ART should be delayed at least 4 weeks and initiated within 8 weeks after treatment of TB. People living with HIV who are already diagnosed with TB but not receiving ART or treatment for TB, TB treatment should be started first and then followed by ART as soon as possible, preferably within the 2 weeks of treatment. This slide indicates the various guidelines, WHO, CDC, BIVA, and European recommendation for latent tuberculosis. So let's see what's happening in Sri Lanka. For latent TB infection treatment, all HIV-infected infants below 12 months who are close contacts of bacteriologically confirmed TB patients, HIV-infected adults, children with a tuberculin test more than 5 millimeters, and HIV-infected adults and children with negative tuberculin or IGRA test should be subjected to a risk assessment by a consultant respiratory physician based on CD4 count and social determinants. Are to be given isoniazid 5 mg kg in adults and 10 mg kg in children with a maximum of 300 mg per day for 6 months. There are other treatment options containing 2 drugs, INH and rifapentine, INH and rifampicin for shorter duration will be available in future in Sri Lanka, but not at the moment, and can be considered after thorough assessment by an expert. So let's see what are the challenges faced when implementing TB therapeutics among HIV patients. As you know, increased liver function at the baseline and at the follow-up visit, which switch the regime bridging therapy. Adverse drug reaction due to both HIV and TB treatment, such as breast syndrome, and shared drug toxicity of medication. Adherence issues when pill burden leads to resistance development to both ART and TB treatment. And drug-drug interaction with anti-TB therapy and rifampicin. So dolutegravir dose should be adjusted as 50 mg BD for the duration of TB treatment and 2 weeks after the TB treatment. Further, drugs levels of dolutegravir may be reduced with rifapentine, and at the moment rifapentine is not available and is costly. So these are my references. And thank you very much for the patient listening.
Thank you, Dr. Himali, for this wonderful presentation. I could just, glance through one of your slides, which is that mother-to-child transmission is 0.3, and that's a wonderful score. Have you reached the elimination criteria for WHO for preventing mother and child transmission? That's a wonderful achievement that you have got out there. We will now move on to the question and answer session with the audience. Now, I would like to let the audience know that we will try to address as many questions as possible that will be coming in through the Q&A box. So if you could just type in your questions, then it would be easy for the presenters to specifically answer your point, your doubts and other connections that you have. So we have all the four speakers now, Dr. Sanjay Pujari, Rajan Kesi, Dr. Himali, and Mr. Robin. Now, I don't see any questions coming up in the chat box, but let's wait for some time. And Dr. Himali, you had alluded to a statement that your latent TB treatment. Have you started with in the format that you have suggested? Testing for IGRA and starting with INH prophylaxis. Have you started that?
Yes, actually speaking, we are giving INH for the latent TB patients, especially in the HIV patient. But sometimes we have to wait, because sometimes when we do the baseline liver function test, sometimes, not always, some patients we do see with the high transaminase level. In that case, we have to wait for some times without starting INH. But it was decided by the consultants who are treating the patients.
Okay. And Dr. Sanjay, what do you think now, this short course therapy that you have recommended, or which you have shown evidence that it is non-inferior to the 6-month regimen for a drug susceptible TB? Now, I'm not putting you on the spot, but what do you think is the future of this IPT? With short course regimen available, IPT of 1 year or 6 months being available, where do you think the world will move?
Oh, I think the world, in terms of treatment of latent tuberculosis, is already in at least the developed world moved to short regimens. Now, the important aspect here is both the treatment of drug susceptible TB as well as prevention of TB includes rifampicin as a crucial element which shortens the duration of treatment. And in the drug susceptible TB, you also have moxifloxacin. So I think rifampicin access, the cost, as the WHO in its consolidated guidelines has mentioned, is a very critical area now that the world needs to look at and try to improve access to. By using rifampicin in both the indications, you can shorten the duration of your prevention as well as you can shorten the duration of your treatment of drug susceptible TB. So I think the key issue is rifampicin and access to rifampicin and affordability, and implementing rifampicin based regimens in the lower and middle income countries and also in our region.
Thank you, Dr. Sanjay. Now, Mr. Rajan, what do you feel? Would you be able to implement these newer therapeutics and the short course regimen, given the problems of the cost and access and availability in a country such as Nepal?
Thank you, Dilip Mathai. I think that's good for us because I'm not a technical person, but as a community, I think the shorter regimen is better for us because this saves us our pills burden, time burden. If also I join my recommendation in here, if we can provide the community best dots on this situation, that is also better for our community. So any kind of implementation of activities has been implemented through community or community based. It's better for better outcome, quality service, good outcome of treatment. Is also very important for us.
Yeah, thank you. Am I not seeing any questions from the chat box, or am I missing it out? There's no. Two questions just arrived on the moderation platform. Do you have that? I'm not able to see that. Could the organizers read those two questions out and to whom it is directed? Okay. Anyway, I think all three nations, okay. We have a question. What is the role of BCG vaccine? Okay, in the light of, either one of the technical people could answer it, either Dr. Carrera or Dr. Sanjay Pujari. What would you say on the role of BCG?
Yeah, so if I can answer that, I think the role of BCG is in kids. As we know, BCG is basically able to prevent severe disease like tuberculosis meningitis in kids. So it's kind of, at least in India, a vaccination which is given at birth to all kids. There is increasing interest in research of trying to give an additional BCG dose, especially in the elderly population, with the idea that BCG immunity may wane and decrease with aging. And there are interesting studies looking at BCG being given revaccination in the elderly population. So, but of course, this is something which is in research stage. We still don't have the results which can be translated into policy. But right now, BCG is predominantly used in kids at birth in vaccination to prevent severe illness in kids.
Thank you, Dr. Pujari. Is Mr. Robin available? I think we have a question for him. Mr. Robin, are you there? Okay, but it would be, because I think it is directed specifically to him. Do you now? This is a little difficult question, but you can still have a discussion on this. But the screen is bouncing up and down. Okay. Sorry. Could you just lower could you just lower down to the fourth and fifth question? Can just scroll down. Yeah. Yeah, that's fine. Do you think there is a decline in TB cases because of COVID pandemic and usage of masks? There's a question because in one of Dr. Sanjay Pujari's slides, he showed a curve upwards which shows that COVID had increased the incidence of TB. I don't know the reason why, but is it because of the use of biologicals? But the question here is, is there a decline in TB cases because of COVID pandemic and usage of masks? Dr. Sanjay, would you like to attempt that?
No, sir. What I showed in my slide is a WHO report showing a decline in TB notifications, which has happened in the year 2020 during the COVID pandemic because of disruption of TB services. This is because of lockdowns, etc., patients not coming forward to get tested for TB, etc. But paradoxically, you see an increase in TB mortality during that year. So that essentially means that people were getting TB, were not diagnosed, and eventually may have succumbed to the disease. So COVID pandemic has disrupted TB, and also showed another slide which shows actually this is one pandemic which has reversed the gains that we have done in TB, NTB strategy over the past 5 years. All the gains that we have done has been reversed in just 1 year of the COVID-19 pandemic. So I think it's not about masks or things like that, but essentially TB has been a significant problem, a hidden problem during the COVID-19 pandemic.
Yes, okay, that clears my doubt as well. Okay, and is rifampicin-based ATT rolled out in India?
At present, from the public program, we don't still have rifampicin included, either both in for prevention amongst people living with HIV or for treatment short course. In the private sector, rifampicin is now being made available as a fixed dose combination with INH. So we can perhaps try to look at using it both for prevention of latent tuberculosis, treatment of latent tuberculosis, as well as short course treatment.
Okay. Yeah. So Dr. Pereira, how sure are you about these numbers? What do you think about accuracy, in terms of how many are hidden from the society in your country, in terms of HIV? Because you've got very good stat shows that, your prevalence of incidence of HIV has also come down.
So if I repeat the question, they are asking me about.
Yes, about your country. Yeah, not I. One of the participants would like to know if the data is robust. Of course, it is robust because it is coming from your national center data. Yes, sir.
So our prevalence is low throughout. From the first patient we have diagnosed in 1987, since up to now, this is 2022. It has been the prevalence among even the high risk group has been very low, less than 0.02. So I think there are several reasons for this. So that one is our high literacy rate and very good preventive programs. And we have our STD programs and the HIV program, both are in one, as we work as one unit. There are no separate STD program or the HIV. Both programs are in one. We work as a one program. It's called STD/AIDS control program. And other thing is there is a very good political commitment, and the healthcare. There are dedicated healthcare workers in our country. So we have the goals and the target. So our target is to end AIDS by 2030. So I think those are the reasons for, and we do a lot of outreach testing for the high risk people, and we do a lot of awareness programs, IECs, condom distribution, and the training for healthcare workers. And we have a good collaboration with the STD/AIDS control program and the people living with HIV. So I think those are the reasons for having low prevalence throughout in our country.
Thanks. Now, there are some questions which are a little beyond the scope of this panelist, but nevertheless, we will try to answer them. Dr. Sanjay, the question goes as, what recombinant vector vaccine in HIV, either for treatment or for, let's say, prevention? If you're...
for a therapeutic vaccine that you can use for treatment along with the ART, the idea is now junked because it was not found to be effective. For preventive vaccine, there are multiple platforms that are being looked into, but mostly the idea is to be able to induce broadly neutralizing antibodies, which are key in trying to prevent HIV infection. In terms of what platforms are used, unfortunately, there was one recent trial called the Imbokodo vaccine study, which used a vaccine vector platform prime boosted, and it failed to show any benefit. I think it was carried out in some African countries. So unfortunately, vaccines for HIV has not been a very exciting area in terms of results. But maybe in future, you may be able to use newer platforms like the mRNA platform, which we now use for COVID, may be harnessed to develop presentation of antigens which are capable of inducing a broadly neutralizing antibody response to prevent HIV infection. But these are all in very preliminary stages of research.
I'll just give you some time to catch your breath, but there's another question that appeared on the screen, and I don't have great experience. My knowledge is only from the newspaper. It's about the Argentinian woman with 100% cure of HIV. Would you like? I've not seen it. I have not seen a review article, but I've seen the newspaper print. Are you? Have you had any reading on this?
Yeah, so the Argentinian patient called the Esperanza patient is basically a long-standing HIV infected individual who was living with HIV for 28 years. She was an elite controller. That means she had very low levels of viral replication or undetectable viral load with good CD4 counts and was not progressing or didn't have any clinical disease. And they then went into to look at her reservoirs, which are basically latent reservoirs. They couldn't find HIV in those, and then they did intensive PBMC sampling. They couldn't find HIV in that as well. The reasons why this, and then this is perhaps a case of sterilizing cure. We don't know how long the woman who never received antiretroviral therapy will continue to remain in this state. So follow-up is going on, and we are unclear about the reasons. But maybe one of the postulates is some of the genes, ApoBac, 3G, etc., may induce lethal mutations in the virus, which can lead to the virus getting non-replicating. So maybe this is just a anecdotal case. Unfortunately, we can't translate those ideas into widespread clinical practice.
Yeah. There's a technical question here, and it's from one of the members. If any of your patients have missed their medicine for about 10 to 15 days, what is the further guideline? What would you do?
I assume this is for tuberculosis, right? If it
no,
is,
I think it is intended for TB is more forgiving, but it's for HIV. Okay, maybe you try to look for both HIV and or TB.
Okay, so for tuberculosis, I think the guidelines are reasonably clear that if in the induction phase with the standard 4-drug regimen that we use for drug-susceptible tuberculosis, if you discontinue it for more than 2 weeks, you need to reinitiate the entire regimen again. But if you discontinue it in the maintenance phase for more than 3 months, then you reinitiate. Otherwise, if it is within this time bounds, you can continue the same TB treatment. That is for drug-susceptible rifampicin-sensitive tuberculosis. As far as HIV discontinuation is concerned, fortunately, at least in India and most other parts of the world, integrase inhibitors are in choice as far as first-line treatment is concerned. And even now, there is data to suggest that you can use them in second line with recycling your nucleosides. So in that situation, interestingly, there's some data which is presented from the NAMSAL study at CROI this year, which looked at if you discontinue your integrase inhibitor based regimen versus an efavirenz based regimen, and you restart the same regimen later on after a gap of say 10 days or 15 days, the chances that you may resuppress the virus is higher with an integrase based regimen. So I think essentially, this issue may not be of a big concern now because integrase resistance is very difficult to get. And that is the reason why you may reinitiate if you're on an integrase-based regimen, the same regimen and follow the patient closely for virological response.
I do agree with you, and my regimen is send the Army, Navy, and the Air Force if anybody intends to stop the treatment. It's you can't afford to take any more risk in the world where you see a lot of resistance both in TB as well as in HIV trials. Now let me give Dr. Sanjay a little break, and then can you scroll down the question box, please, so that let me see if see I don't can't see. Okay, Dr. Sanjay, once again to you. How prevalent is HIV-2 in India, and what's the differentiation assay that you use for diagnosis? And then can you share your experience with any patient with HIV-2?
Yeah. So we see HIV-2 infections. In fact, we have one of the largest publications of use of dolutegravir in HIV-2 infection. If you look at the prevalence in India, it may vary from about 1 to 1.5%. It's very easy to diagnose HIV-2 infection in India. You start with a third generation ELISA to screen for HIV infection. And if it is positive, you do a rapid test, which differentiates. It's a lateral flow assay, which is available very cheaply in India. And you can differentiate between HIV-1 and HIV-2 in that. And then subsequently, you can treat the patient. As we all know, HIV-2 doesn't respond to non-nucleoside reverse transcriptase inhibitors. You need to use dolutegravir integrase inhibitor based regimen, or you can use a protease inhibitor like lopinavir, ritonavir, or darunavir, ritonavir in this context with the backbone of 2 nucleosides. So I think HIV-2 is less prevalent in India, but it is not that it is something which can't be treated.
And it wouldn't. What about children's booster vaccine for tetanus or diphtheria? Now we use booster dose even in COVID-19. Why? The question here is, I think, let's take the children's part of it. The children's booster vaccine for tetanus or diphtheria is basically to increase the immune levels as such. Now, that's a little different from the booster dose that we are using now in COVID-19. We call it as the precautionary dose, or making sure that, after 9 months, the antibody levels, the neutralizing antibody levels are waning, and therefore you're giving the booster dose. But primarily, these doses have acted upon your T cell memory cells, and we don't know, and we think that the protective immunity is there. That's a little different from the tetanus and the diphtheria vaccines that you're using in children. So, and then Dr. Sanjay, what would you think? The booster dose?
I certainly agree with your comment. I think for COVID-19, it is very clear that neutralizing antibody response wanes over a period of time, and it basically makes people susceptible to get infected. But as you rightly pointed out, if you're able to stimulate T cells, they are able to prevent you, and if you're able to build immune memory with B cells and T cells, they're able to prevent hospitalizations and severe illness. So the whole purpose of boosting is to stimulate memory response, keep presenting the antigen 1. The second is, of course, later on in the COVID pandemic, if at all you will get annual boosters or something like that, that will be tailored to the predominant circulating variant, and that is what we are seeing in influenza. So I think that is another reason why you may need annual boosters if COVID-19 continues to develop new variants, and if there may be seasonality associated with it, then over a period of time you may need, and that is another reason why you may need boosters.
Thank you. Can we just scroll down? I think most of the questions, can you just scroll down? Yes. Dr. Per, yeah, go down. Yeah, just keep going. Yeah. Please advise for what were your, just 1 minute. Yeah, Mr. Rajan, you're there. What are your Mr. Rajan? Yeah. Sorry. So, what are your thoughts over the rights of your health data? In other words, what they're asking is, how do you use it for advocacy, and also for innovation, research, and development? How do you use your because I didn't see any data from Nepal, but what our participants are asking is, if you had some data, how would you use it for advocacy? In other words, what do you have any methodology?
Okay.
Yeah, please.
To be frank, till now there is no any community group for advocating TB issues. So we form a National TB Network. We have only a diagnosis treatment program only. So we have to work many things in Nepal. on advocacy for better treatment, health right, human right. So we have to work many more things. Still in Nepal, there are many cases as missing because of social stigma or unaware about the treatment, unaware about the problem. So we have to work many things on Nepal. So till now, we don't have any that kind of advocacy issues or advocacy practices in previous year. So we have to plan to work on these issues as well from Digital TV network.
Thank you. Thank you. I think as I've been scrolling down this question box, and I find that some of the questions are overlapping and most of them have been answered. But I think because we're running short of time, is best. I think we may have to move on. Let me take this opportunity to thank all of the speakers. I really enjoyed your presentation and really appreciate it and the time that you have spent, and to all the participants. But I would like to now pass it on to Dr. Ishwar Gilada to give his closing remarks. Thank you very much.
Thank you, Dilip. Thank you very much for wonderfully moderating this session. It was a very lively session. Thank you once again to all the speakers for their very interesting presentations, both yesterday and today. This concludes the IIS Educational Fund Symposium. We would also like to thank all the participants, and we hope that this session has been helpful and interesting to all of you. There have been galaxy of speakers, moderators, co-chairs both the days. On behalf of IIS, I would like to also sincerely thank all the staff of Asha Foundation connected from India, who have been incredibly helpful and have worked very hard in organizing all the behind the scene to bring in front of the scene for this symposium. We would also like to once again thank Vive Healthcare for their generous support of this virtual meeting and for making it possible to make all of you to meet. This has been a wonderful meeting. It would have been further wonderful had we met personally. We hope that the information shared and discussed during this session will help you reflect on a personal as well as professional level and help understand the lessons learned from COVID-19 pandemic for the HIV response in South Asia. Yesterday, we had excellent sessions on advanced HIV disease. And after that, we had a discussion with NACO, and NACO is going to have a separate meeting on just advanced HIV disease. So such kind of meetings, which leads to another meeting, is a wonderful experience. And we had all the very good friends where we over last 2 or 3 decades, we have been meeting often. Vivek Raj Anand, Jalpa Thakkar, Daksha, Sajid Kumar, Manoj, Tawfiq, Sanjay, of course, we meet often. Currently, we haven't met for 2 years almost. Dilip, we interact almost on weekly or daily basis. Anand, Sunil, and what we have seen also the collateral damage caused by the COVID pandemic. And sometimes we get into fool's paradise that TB is less, but we know that a lot of people died, as Sanjay told just now. We also hope that by participating in this symposium, we'll have received new ideas and solutions to face challenges encountered at work, new ideas on how to implement some of the latest science at your local as well as regional levels, opportunities for new collaborations to enhance policies and practice in HIV, strategies on how to improve policies and practices that currently are in place in the region, new contacts which we could have made by using the chat features on the virtual platform. We very much hope you can exchange details and continue building relationships within the region that lacks regional meetings and conferences, unlike other regions. So we didn't have any regional conference in last 6 years, and before that it was 3 years before. So 2013, 16 till today there is no Asia Pacific conference. So we hope IIS can do more meetings like this. I would also like to thank all the participants who sent questions during the discussions, and we also encourage you to share the recordings of the symposium with your colleagues who were not able to participate with us live yesterday and today. These will be available soon on the IIS Educational Fund virtual platform, which will be free of charge, and they can join the platform anytime to watch the replays, which will be available next week. I am now pleased to pass on this floor to Dr. Glory Alexander, Director of Asha Foundation, to close the symposium. Thank you very much. Over to you, Glory.
Thank you, Dr. Gilada. On behalf of Asha Foundation, thank you to our speakers for their contribution and participation in this session and in the symposium as a whole, especially during this special and very busy time of the year. In my concluding remarks, I would like to say that these 2 half days of the symposium titled HIV Science and Community in South Asia, Keeping HIV Responses Effective in Pandemics, has been a revelation. This symposium has showed us that by following the science and by involving the community, who are the key stakeholders, much can be achieved. The COVID-19 pandemic has been and continues to be one of the darkest times of our world. But even in the darkest of times, one should remember that there is always room for a little light. Sometimes bad things have to happen for good things to happen. And so we have heard about some of the innovative best practices for HIV that have evolved out of this pandemic, out of this COVID-19 pandemic. One example being the self-testing for HIV at home with online support. 10,000 people accessed the service over a period of a very few months, and around 3,000 of them self-tested, and we found a zero prevalence of 5%. Surely this is a measure that needs to be scaled up. Then involvement and empowerment of key populations to provide peer-led integrated services for HIV. Virtual online support for young people grappling with mental well-being issues, not only young people, but also the older adults. Virtual interventions seem to be one way that can be used, as has been found to be a fairly successful method during the COVID-19 pandemic. We all know that ART has now been available for almost 30 years, and we all know that ART is the reason that has transformed HIV infection from a fatal, life-threatening illness to a chronic, manageable illness. And yet, in this time and age, 30% of patients who come to us for HIV care are in an advanced stage. And this is very sad, especially when ART is available. So it's important that in the South Asia region, guidelines be formulated on an urgent basis for management of advanced HIV care. And it's also important to scale up all along the cascade of services available for HIV, from awareness to testing to expansion of PrEP services to care and support, adherence and follow-up, and to use innovative approaches. At the same time, keeping in mind the cross-cutting issues like decreasing the inequalities that exist and maintaining human rights. Today's session on injecting drug use was an eye-opener on the huge gaps that exist in the healthcare system for this key population. At the same time, again, COVID-19 brought out that it is possible to provide take-home OST, which was always being given under supervision till now, and giving ART for longer periods of time might work in the population. An important change may also be to do away with punitive and discriminatory laws, which actually impede rather than facilitate access to services and worsen stigma and discrimination. Regarding tuberculosis, the innovative approaches for drug susceptible TB to look at preventive therapy to look at shorter regimes with fairly newer drugs with non-inferior response. And I'm sure this will become one of our guidelines in the near future. And besides, it helps in improving the compliance and not decreasing the toxicity. The unfortunate thing was that during the COVID pandemic, there was a decrease in TB notification and increase in TB mortality. The other thing, of course, is the digital technology and artificial intelligence-based software, which has helped in reading of radiographs more precisely and in a much shorter period of time. And that would be the way to go in the future. We also need to remember that pilot programs, which have been pilot studies, which have been successful, need to be changed to programs, and programs need to be scaled up. These are some of the recommendations that I would suggest following the end of this symposium. We would like to thank the Program Building Committee, the Advisory Committee for their inputs in putting together this incredibly interesting program. I would like to thank 3 people from the IAS Educational Fund team, Julia Valiant, Joanne Gabani, and Laure Felix Boxer for their continued input and support to Asha Foundation. I would like to thank Dr. Gilada, who is the member of the Governing Council of IAS, as well as the representative for the for Asia and the Pacific region, for the support that he has provided to us always. I would like to thank my Asha Foundation team, especially Sylvia Pratibha Thomas, Ramya Allen Thomas, and Mercy Priyanka Isaac for the support that they have provided. We are going to miss the meetings, the weekly meetings that we had with IAS over the last 3-4 months. I'd like to thank Ben Stilwell for your support, technical support for this program. We hope that this meeting has helped address the key areas where we need to enhance discussions and actions for our South Asia region. We are also pleased to remind you that we will be hosting a short networking event at 6:45 p.m. Indian Standard Time, right after the end of this symposium. It will be held on Zoom, and you will be able to network with symposium speakers and panelists, providing an opportunity for you to ask additional questions in a more informal and intimate setting. Because this is a virtual meeting, we do not have otherwise opportunity for people to meet and share a cup of tea. So we thought a network meeting on Zoom could at least be an answer. The registration link for this Zoom meeting has been shared in the chat box. So please register if you're interested in joining, and we hope to see you there very shortly. Please also remember to participate in the evaluation survey at the end of this meeting for the overall symposium. All participants will receive an email on Monday requesting that you fill in a survey to evaluate the symposium. We would greatly appreciate your feedback, which will help us to continually improve our symposiums in the future. And you can also write to the IAS Educational Fund team anytime at iasedu@iassociety.org. So that's all for now. Thank you, and see some of you soon. Thank you. Good night. Have a good rest of the day.